The following is a summary of the article titled A Review of the Pharmacology and Clinical Applications of Levetiracetam in Dogs and Cats. This is a very detailed article to keep on hand if you are able to obtain it. Starting with the introduction, levetiracetam Lev was approved in 1999 as an adjunct for refractory partial seizures in human epileptics. It exhibits linear kinetics, 95% absorption, minimal protein binding, limited hepatic metabolism, and a half-life of 6 to 8 hours. Several animal models have confirmed the safety and anti-epileptic properties of Lev. Treating epilepsy in small animal veterinary patients can be expensive with undesirable side effects. Consequently, seizure control or AED side effects may result in euthanasia. Lev is effective as an adjunctive therapy for refractory epilepsy in healthy dogs and cats. However, its usefulness as a first-line monotherapy AED in small animals with epilepsy is yet to be determined. 2. Epilepsy and its treatment. Epilepsy is a brain disorder that causes seizures due to sudden and abnormal neural activity. Epileptic patients often experience brief and episodic seizures due to various underlying causes such as trauma, infection, or cerebral vascular events. Focal epileptic seizures affect specific areas of the brain associated with abnormal motor, autonomic, or behavioral manifestations, whereas generalized epileptic seizures affect the entire brain, resulting in tonic-clonic, or myoclonic episodes. Dogs have a higher prevalence of epilepsy than cats, and the earlier implementation of anti-epileptic drug AED therapy is associated with better clinical outcomes, particularly in severe epileptics. A recent study from the United Kingdom reported that around 0.16% and 0.04% of cats experience recurrent seizure disorders and epilepsy, respectively. There is an association between higher seizure frequency before initiating AED therapy and subsequent clinical failure in humans with epilepsy due to the intrinsic severity of epilepsy and individual response to treatment. Evidence-based guidelines are available to aid in treatment decisions for people with epilepsy, but there are no established guidelines regarding AED initiation or choice in small animal epileptics. However, 2 recent consensus statements address these topics. Phenobarbital, potassium bromide, and imepitoin are common initial AED therapies in small animal patients. Although limited, clinical data suggests zonisamide and Lev are effective in small animals. Oral Lev, available in immediate and extended release formulations, is a cost-effective adjunctive or alternative therapy to other AEDs in small animals because of its wide safety margin across species and favorable pharmacokinetics, with a unique mechanism of action. 3. Mechanism of action. Anti-epileptic drugs AEDs that are currently available act through 3 primary mechanisms: facilitation of inhibitory neurotransmitters, i.e. gamma-aminobutyric acid, GABA, or inhibition of excitatory neurotransmitters, i.e. glutamate, inhibition of Na+ channels, or modulation of Ca2+ currents. However, these mechanisms can lead to seizures persisting in drug-resistant patients and detrimental side effects. As an alternative, AEDs that were developed to target new pathways have emerged. Several AEDs have been introduced as safer options for seizure control in humans, but few are approved for the same use in small animals. Lev-Keppra has been proven effective and safe across numerous species. Lev works in a distinctive way by interacting with protein 2 of the synaptic vesicles, SV2, which is a 12-transmembrane integral 90 kDa protein that is extensively distributed in the brain. While the function of SV2 remains unclear, it appears to act as a modulator of vesicle fusion. As a result, seizures are inhibited by preventing the release of neurotransmitter-containing vesicles or vesicles containing cofactors of action potentials, i.e. calcium, ATP. Commercially, SV2A subtype is the target of Lev. Moreover, Lev also affects the release cycle of inhibitory and excitatory neurotransmitters. The role of Ca2+ handling in preventing the formation of action potentials and neurotransmitter release is crucial. Lev leads to the modulation of voltage-dependent Ca2+ channels to reduce glutamate release in the dentate gyrus of the hippocampus, an area where seizure activity is common. Additionally, it reduces seizure potential through increased presynaptic inhibition of GABA and glycine inhibitory activity and decreased excitatory transmission. While Lev has failed to prevent acute seizures caused by electroshock or pentylene tetrazole injection, it has demonstrated its efficacy in chronic seizure models. Lev has also demonstrated success in unique settings such as prevention of partial seizures, audiogenic seizures, and photogenic seizures. Kindling, a permanent change in brain function that results from repeated focal stimulation and ultimately leads to an increase in the duration and intensity of seizures, is also decreased by Lev activity in multiple animal models. In addition, Lev tends to prevent aberrant neuronal discharge and neuronal hypersynchronization. Experiments show that Lev leads to a reduction in neuronal activity, even after exposure to GABA receptor antagonism and NMDA receptor agonism. Thus, the anti-epileptic effect of Lev may occur through an overall decrease in aberrant neuronal discharge. Finally, Lev showed a reduced magnitude of neuronal activity in left-treated preparations compared to those treated with traditional AEDs. Stimuli-inducing hypersynchronization of neurons in rat hippocampal slices have elucidated that neuronal hypersynchronization is excessive integrated activity of many neurons in a particular area of the brain, and that this is implicated in the formation of epileptic discharges and epileptic syndromes. 4. Pharmacokinetics and pharmacodynamics in people. Lev shows a linear pharmacokinetic profile, making dose titration for seizure control simple, and plasma concentrations consistently remain within the therapeutic range. Lev's bioavailability is high, with rapid absorption achieved within an hour after oral administration. Additionally, Lev crosses the blood-brain barrier in a dose-dependent manner and achieves steady-state concentration after 48 hours. Lev's volume of distribution is 0.5 to 0.7 lkg, and its half-life is 6 to 8 hours, allowing for twice-daily dosing. The half-life of Lev in brain tissue is longer than in serum, indicating a prolonged action of Lev at its target tissue. Lev's results show minimal metabolism, with most of the drug eliminated unchanged by the kidneys through glomerular filtration. Therapeutic drug monitoring may be needed in certain patient populations. Although Lev may cause a honeymoon effect in some patients, where its efficacy is more significant, it stabilizes over time. If patients experience continued breakthrough seizures, adjustments in Lev dosing should be considered. After a scoring system for anti-epileptic drugs was developed, Lev, along with vigabatrin, scored highest. Lev lost a single point in this scoring system due to partial metabolism. 5. Pharmacokinetics and pharmacodynamics in small animals. Lev has similar PK in small animals as in people. In dogs and cats, almost all orally administered Lev is absorbed, although giving it with food can slow absorption. The majority of Lev is eliminated unchanged in urine, with only a small percentage being hydrolyzed to the carboxylic acid metabolite. The intravenous administration of Lev results in plasma drug concentrations above the human therapeutic range, but the intramuscular and rectal routes showed similar drug concentrations to oral administration. The availability of oral lev is in both immediate release IR and extended release XR formulations. A 20 mg/kg dose of oral IR lev given every 8 hours to healthy dogs resulted in peak plasma drug concentrations consistently within or above the human therapeutic range. In healthy dogs, a 4-5 hour T1/2 of oral XR lev is longer than IR lev, supporting the current recommendation for every 12 hours dosing of this formulation. However, dosing recommendations for XR lev in veterinary patients are difficult to generate due to limited data. Intravenous doses of lev in dogs or cats should consider the lower renal clearance in these species. Although there are advantages to XR lev, such as improved owner quality of life due to once or twice daily dosing, recommendations for its preferred use cannot be made due to limited data on its clinical efficacy in small animals. Intravenous and intramuscular lev doses result in similar plasma drug concentrations as the oral route in dogs, and rectally administered parenteral lev shows a rapid onset to reach therapeutic plasma drug concentrations within 10 minutes in healthy dogs. Bioavailability studies of lev in healthy cats showed that orals and IV administered lev achieved plasma drug concentrations above 5 ml within 10 minutes, with the values being similar to those found in dogs. Twice daily dosing of XR lev in cats may provide adequate seizure control, but consideration should be given to the commercial tablet size of XR lev, where the smallest tablet size may result in an excessive dose. Transdermal application of lev to the inner ear pinna of cats is a potential alternative for owners with cats that are difficult to medicate orally. Concurrently administering lev with other AEDs may lead to the need for higher or more frequent dosing of lev, as demonstrated in dogs receiving lev therapy and phenobarbital PB. Although zonisamide does not significantly alter PK of lev, the honeymoon effect may occur in dogs receiving lev in addition to other AEDs, causing an increase in seizure frequency and seizure days. 6. Drug safety and adverse effects. Lev is generally safe for use in all species, providing a high margin of safety. Although adverse events in healthy people receiving lev were frequently reported, they were usually mild and short-lived. Most untoward effects manifest in the CNS, including postural dizziness, somnolence, and fatigue. These adverse effects were seen regardless of the administered dose or rate of infusion. People receiving oral lev as an adjunctive therapy for refractory epilepsy reported more side effects, such as somnolence, dizziness, and asthenia, but their incidence decreased with decreasing dosages. Blood work changes observed in clinical trials after lev use were limited to decreases in red and white blood cell counts but were not significant enough to discontinue the drug. In canine safety trials, oral lev dosages up to 300 mg/kg day were well tolerated, with few dogs exhibiting adverse effects. Neither extravasation nor IM injection led to the development of tissue inflammation or persistent pain. Cats receiving oral lev experienced transient hypersalivation and mild sedation and CNS signs. A meta-analysis found strong evidence that lev is safe for use in dogs with seizures. An additional study confirmed the potential for lev to negatively alter patients' behavior. Although acute hypersensitivity and anaphylaxis to lev are rare, they have been reported in both dogs and humans. 7. Levetiracetam for epilepsy in people. 3. Double-masked, controlled trials demonstrated lev's efficacy as an adjunctive treatment for partial seizures. The addition of lev in these studies led to more treatment responders than placebo, and in some patients, a higher dose of lev led to successful substitution as adjuvant therapy. In human clinical trials, lev at a dosage of 3,000 mg day resulted in 8% of drug-resistant patients becoming seizure-free. The addition of lev was beneficial to people suffering from idiopathic generalized epilepsy or post-traumatic partial epilepsy. Lev reduces seizure frequency, increases seizure freedom, and may be useful for treating status epilepticus when other therapies have failed. A cohort of 228 people with variable epilepsy etiologies remained seizure-free for at least 1 year at a median lev dose of 1,000 mg day. Seizure freedom was more common for those patients in whom lev was the first monotherapy AED, and for those who experienced fewer seizures before starting lev therapy. 8. Levetiracetam for epilepsy in dogs. Clinical trials investigating levetiracetam lev as a monotherapy or adjunctive anti-epileptic drug AED for dogs with epilepsy have yielded disparate results. One prospective study administered lev at a dosage of 10 or 20 mg/kg orally every 8 hours to 14 pharmacoresistant dogs. Within 4 months, 9 dogs showed a response, defined as a 50% or greater reduction in seizure frequency. But, in 66% of responders, seizure frequency increased again 8 months after lev therapy started, due to a honeymoon effect. The majority of dogs in this trial had complex partial seizures and were being treated with 2 AEDs before receiving lev therapy, which are patient variables that suggested refractoriness to anti-epileptic therapy. Another randomized, double-blind, crossover study compared lev, 20 mg/kg orally every 8 hours, to a placebo in dogs with epilepsy that was refractory to potassium bromide, KBR, and phenobarbital PB therapy. Although the drug was safe, they couldn't show efficacy over the placebo. The high dropout rate, large placebo effect, and predominance of dogs with severe, refractory epilepsy weakened the study. A retrospective study evaluated the efficacy of 2 lev oral regimens for chronic epilepsy in dogs, many of whom were already being treated with other AEDs. The treatment protocols included the maintenance 20 mg/kg orally every 8 hour and pulse 60 mg/kg orally initial dose after a seizure or signs of one, then 20 mg/kg orally every 8 hour protocols, following a mean treatment duration of 1.4 years. About 70% of dogs showed a 50% or greater reduction in seizure frequency with either regimen, and 7% were seizure-free. The proportion of dogs with cluster seizures decreased from 90% to 27%. The authors suggested that treatment protocol, type of epilepsy, and AED use before adding lev did not affect treatment success. The heterogeneity of the cohort in this trial could lead to a more favorable effect of lev compared to the 2 previously described studies. Intravenous lev was compared to placebo in dogs with acute repetitive seizures or status epilepticus. The study involved 19 dogs that received lev, 60 mg/kg intravenously, or placebo, 0.9% saline intravenously, in addition to the standard of care, 0.5 to 1 mg/kg of diazepam intravenously. The responder rates, dogs that had no additional seizures for 24 hours after presentation, in the lev and placebo groups were 56% and 10%, respectively. However, a small sample size might explain the non-significance difference. Lev as a monotherapy AED was evaluated in 2 studies involving dogs with epilepsy. In a study involving dogs with idiopathic epilepsy that exhibited at least 4 seizures in the preceding 6 months, PB or lev was administered to 12 dogs. All 6 dogs that received PB showed a response, at least 50% reduction in monthly seizures, while none of the lev dogs achieved seizure control. Another retrospective trial investigated lev as monotherapy in dogs dogs with structural epilepsy receiving oral lev at a dosage of 937 mg/kg every 8 hours. Within 3 months of starting treatment, 10 of the 19 dogs showed a great response. No seizures after beginning lev and an interictal period of more than 3 months, and 7 of them had complete seizure freedom. The percentage of cluster seizures in the 19 dogs decreased from 68% to 16%. The authors also mentioned that drug therapies implemented for these processes, e.g., glucocorticoids, could influence the perception of clinical response to lev. In a review of using lev in a larger, heterogeneous cluster of 205 dogs with epilepsy, patients were partitioned into 3 groups: lev monotherapy, 46%, multi-drug therapy with lev and PB, 34%, and multi-drug therapy with lev and other agents, without PB, 15%. Lev was given orally as IR lev at median dosages of 22.6 mg/kg every 8 hours or as XR lev at median dosages of 29.5 mg/kg every 12 hours. The duration of therapy was typically 75 days, although pharmacokinetic parameters for both IR lev and XR lev were in line with those reported earlier. Plasma drug concentration had no relationship with clinical response. Dogs who got lev and PB concurrently were 1.8 to 2.5 times more likely to have a trough lev concentration below the reference range. Among 77 patients, 37.5% seizure control, at least 50% reduction in seizure frequency compared to baseline, was found, and 61% of those maintained seizure control with lev monotherapy. 9 levetiracetam for epilepsy in cats. In a study involving 12 cats with suspected epilepsy, levetiracetam lev was administered as an adjunct to phenobarbital PB therapy. The cats had follow-up times of 6 to 24 months. Of the 10 cats, 7 were classified as lev responders with a median reduction of 92% in seizure frequency. A prospective randomized trial compared lev to PB in cats with suspected audiogenic seizures and associated myoclonus. Cats eligible for enrollment had a minimum of 12 myoclonic seizures in the preceding 3 months. A favorable response, at least a 50% reduction in seizure frequency, was demonstrated in 100% of cats given lev, and only 3% of cats given PB. Additionally, the frequency of myoclonic seizures was reduced in the lev-treated cats compared to those receiving PB. After transient side effects, all cats receiving lev were brighter and more interactive. The study's authors theorized that lev success in this patient cohort may stem from its ability to reduce kindling. Early lev therapy's ability to prevent progression of audiogenic seizures from myoclonic to generalized tonic-clonic seizures is yet to be determined. 10 levetiracetam and other neurologic diseases. Lev has been studied in humans for the prevention and treatment of seizures associated with various conditions, such as stroke, brain injury, and CNS malignancies. While clinical data is limited for veterinary patients, lev may have wider use in emergency and critical care, including CPSS, neuroglycopenia, TBI, and cognitive impairment. 11 congenital portosystemic shunts. Surgical attenuation of congenital portosystemic shunts, CPSS, in dogs can lead to neurologic complications such as ataxia, blindness, and post-attenuation seizures, PAS, with incidence rates ranging from 3.6% to 17%. Cats are more commonly affected, with up to 60% developing PAS post-surgery. Mortality rates are high, between 4% and 22%, with seizures typically occurring within 96 hours post-surgery. Contributing factors include a reduction in benzodiazepine-like receptor agonists, hypoglycemia, hepatic encephalopathy, hypoxic brain injury, electrolyte derangements, aberrations in systemic blood pressure, and concurrent brain disease. In dogs, risk factors include immediate postoperative hepatic encephalopathy and increasing age, and in cats, a lower postoperative serum osmolality. Studies involving levetiracetam, lev for PAS prevention have not had consistent results. While more research is needed to determine lev's role, the authors suggest using lev preemptively in surgical CPSS patients due to its availability, affordability, and safety. 12 neuroglycopenia. Hypoglycemia is common in pets brought to veterinary emergency rooms. The causes include insulin or insulin analog excess, toxins such as xylitol, inadequate glucose production, hepatic dysfunction, and hypoadrenocorticism. Hypoglycemia adversely affects the brain since it relies solely on glucose for energy, thus making it particularly vulnerable. It leads to dysfunction of the NOK-ADPase pump and neuronal swelling resulting in cellular apoptosis and necrosis, even when blood glucose concentration returns to normal. Hypoglycemic encephalopathy, a comatose state associated with seizures, is a risk people with prolonged or severe hypoglycemia are exposed to. It has a 60% mortality rate. Seizures are not uncommon in small animal patients suffering from systemic hypoglycemia. In the author's hospital, benzodiazepines are used for immediate seizure control, with lev being recommended for long-term seizure control. Veterinary patients experiencing seizures after hypoglycemia should consider short-term anti-seizure prophylaxis. Using lev due to the increased morbidity and mortality associated with neuroglycopenia and hypoglycemic encephalopathy in people. 13 traumatic brain injury. The current guidelines for individuals experiencing acute moderate or severe traumatic brain injury (TBI) suggest using anti-epileptic drugs AEDs for at least 7 days to prevent post-traumatic seizures (PTSs). If no seizures occurred during this period, AEDs can be discontinued. Though this approach may reduce short-term seizure occurrences, it does not affect long-term seizures. Earlier, phenytoin was commonly used for this purpose. However, there is a marked preference for using lev instead. While different small clinical trials are assessing lev's suitability as an AED, the Brain Trauma Foundation TBI guidelines still consider there to be insufficient evidence to recommend lev over phenytoin. However, using lev showed lower disability scores for patients after 3 months and better Glasgow outcome scales after 6 months of the injuries than phenytoin. In veterinary medicine, no standardized guidelines exist for prophylactic use of AEDs in small animal TBI cases. Though PTSs have been reported in dogs and cats, various studies suggest that 6.6% to 36% of dogs with TBI may develop PTSs, with higher risks for dogs with skull fractures and severe injuries. Some studies recommend prophylaxis with benzodiazepines or phenobarbital, although lev's first-line use is considered viable for prophylaxis in moderate or severe TBI cases. While PTSs occur infrequently in animals with TBI, Severe injury and skull fractures significantly increase the chances of their occurrence. Seizures can lead to further brain damage due to increased cerebral oxygen demand, making prophylaxis desirable. Thus, using lev as prophylaxis for PTSs in moderate or severe TBI can be considered a reasonable first-line approach. 14 other intracranial effects. Lev has shown neuroprotective effects in animal models of cognitive dysfunction. In rats with induced seizures, lev prevented reductions in mitochondrial enzyme activity and increased brain concentration of the antioxidant glutathione. Mouse models of dementia showed that lev alleviated behavioral deficits, reversed hippocampal remodeling, and improved deficits in long-term memory. Lev also improved motor function, vestibular performance, and reduced neural injury in murine models after subarachnoid hemorrhage. It decreased the damage to cultured neuronal cells, reduced the infarct volume by 33% in a murine model of focal cerebral ischemia, and improved cognitive function in people receiving it. Lev was found to improve neuropsychological parameters, reaction times, and the ability to process simultaneous stimuli in human patients. It also improved memory, motor function, verbal fluency, and attention in elderly epileptics. Alzheimer's patients with epilepsy treated with lev showed improved oral fluency and attention, and other forms of cognitive impairment demonstrated significant overall improvement. The exact mechanism of the beneficial effects on cognitive function is yet to be determined. Still, studies suggest that lev reduces neuronal hyperactivity in the hippocampal region and restores normal neuronal activation patterns in people with cognitive impairment and epilepsy. Lev inhibits ryanodine and IP3 receptor-activated neuronal calcium release and reduces swelling in mitochondria, which may reduce neuronal hyperexcitability in Alzheimer's patients. Lev may benefit certain older dogs with cognitive dysfunction and myoclonic epilepsy. It can extend beyond control of the epileptic state to improve the quality of life by improving sleep-wake patterns and reducing propulsive pacing behavior. 15 clinical recommendations in small animal veterinary patients. This article outlines recommendations for using lev as an AED and for treating other neurological conditions in small animals. The authors base their advice on a thorough review of literature in addition to over 15 years of clinical experience. Lev is available in 250, 500, 750, and 1000 mg tablets for oral administration as well as a 100 mg colorless solution for parenteral use. While the optimal dosage is unknown, recommended oral and IV dosages range from 20 to 40 mg/kg every 8 hours, with adjustments made as needed to achieve seizure control. In our clinical use, we prescribe an initial dosage greater than 20 mg/kg (PO) every 8 hours, followed by titration to maintain seizure control. If necessary, doses can be doubled to overcome the honeymoon effect of this drug. Lev has shown to be safe up to dosages of 1,200 and 1,800 mg/kg day in adult and juvenile dogs, respectively. Dose reduction may be necessary for patients with renal impairment or hepatic failure to avoid sedation. A loading dose may not be necessary for patients not experiencing cluster seizures or status epilepticus, as IV doses of 20 and 60 mg/kg maintain therapeutic plasma concentrations for at least 8 hours. However, we do administer a loading dose, 60 mg/kg, IV to patients with active seizures upon hospital presentation. Lev is not usually diluted nor administered as a slow infusion, but rather given as adverse reactions have not been noted. The authors also recommend using similar lev dosing regimens for other neurologic diseases in small animal patients. Therapy should be continued for at least 10 days following hospital discharge, with longer treatment courses and increased dosages dictated by individual patient responses. Lev therapy does not require tapering in small animals. Lev has proven to be a safe and effective adjunctive AED in small animal patients and may even function as a reasonable monotherapy, particularly in cases of audiogenic seizures. In cats, with its broad indications in human critical care, lev may have further potential for treating other neurologic disease processes in small animals as well. Additional clinical studies are encouraged to explore its efficacy further.